Hello, welcome to the Black Men Speak podcast live stream. My name is Keith Dent. I'm the host for tonight's show and every show for that matter. And I just am grateful that we're going to be having this conversation tonight. The topic is going to be on sexual dysfunction or erectile dysfunction and prostate cancer. And the reason why I wanted to do this is because a couple weeks ago, a friend of mine by Dr. Madeline Sutton, shout out to Dr. Sutton, who is a Georgetown alum, but I saw her as I was getting prepared for my show a couple weeks ago. She did a Facebook Live, and she was talking about female sexual health because she's a doctor of obstetrics and gynecology in Atlanta. And so I was very inspired by the candor and the openness of the program. And I said, well, immediately I was like, we needed to do this from a black male perspective because, it's just not something that we normally we're going to talk about out in the open. But we really need to talk about it, because, if you didn't know, 18 million American men deal with erectile dysfunction. But, the overall sexual health of black men, we just don't talk about. It's portrayed in the media, that, erectile dysfunction is something that happens by other men, specifically white men, because if you look at the Cialis and, the other commercials, that's their issue and not ours. And it may be because, they feel that, black men are maybe hypersexual beings. And so, why would we have these issues? But we do have these issues and they need to be discussed. So in fact that, like I said, 18 million American men deal with erectile dysfunction. And African-American men are more likely to experience erectile dysfunction when compared to other races. And even though our health care is improved for black men, this, still remains a mystery. And I saw an article in blackamericaweb.com that, that in order for us to find a solution, this is some things that we need to discuss. And then in regards to prostate cancer, African-American men are at increased risk for developing prostate cancer over white men and other men of color. And 1 in 6 African-American men will develop prostate cancer in his lifetime. And overall, African-American men are 1.8 times more likely to be diagnosed diagnosed with and to 2.2 times more likely to die from prostate cancer than white men. And so it's very interesting, because, I saw some studies and I'm going to talk about it with our guest that, it doesn't necessarily mean that there may be some issues in regards to why we're dying. Are we being diagnosed correctly, or are we just not going to the doctor, or we don't, how it goes in our community. A lot of times we don't trust doctors and or just feel like, why is it worth going? But, we have to start doing these things. So to get to the truth and our questions, I turned to Dr. Nyame and Yaw A. He's a surgeon, researcher, educator, and patient advocate who specializes in urological oncology and general urology. His clinical interests include open and minimally invasive kidney, prostate, bladder, and testicular cancer surgeries. Dr. Nyame attended medical school at the Feinberg School of Medicine at Northwestern University and business school at the Kellogg School of Management at Northwestern University, graduating in 2012. Prior to medical school, he completed a master's in health services administration at the School of Public Health at George Washington University. So not far from my alma mater down the road. And so just by base that we have a smart brother that's going to be on tonight that's really going to help us and answer the questions that we know we need to ask. And so currently he's completing a general surgery internship and urology residency training at the that was from previously the Glickman Urologic and Kidney Institute at the Cleveland Clinic, but he's currently at the University of Washington. So let's bring him up. And Dr. Nyame, am I pronouncing that correctly?
Yeah, Yaw Nyame.
Yeah, Nyame.
Yes,
Nyame.
sir.
Yeah, great. Well, welcome tonight. I'm glad that you're here because, as I said earlier, this is just not something that we as African American men talk openly about. And so, and I was doing my research, and I was like, I've got to find a brother that can really break it down for us and answer our questions. So I'm glad you're on this evening.
Well, I want to start by saying thank you. This is an area that I'm very passionate about in the research that I do. It's an area where we need to make improvements, and so anytime I get an opportunity to have this discussion, um, I find it to be really fruitful and important thing to do. So,
Oh, great.
thank you.
And since you said you are passionate about it, what made you decide to go this route and focus on urology?
Mentors, when I was in Chicago, there was a young black urologist by the name of Adam Murphy. He was at Northwestern. He had just joined the faculty, um, and he was a role model. I was at this big academic institution, with a lot of big names, a lot of important people around, and there was a shining example of what I could potentially be in Dr. Murphy. And so I knew I wanted to do something surgical, but it really was identifying a role model like him that led me to urology.
Great. And yeah, that's really important because, role models are very helpful. And when we're able to find one that can really, direct us on our path, whatever the career is, it makes it really beneficial and and adds a lot of peace, especially as doctors, because we really need to have someone that guides us. I know there's probably just so much to know and learn, and when you can have someone that can point you in the right direction, I'm sure that was very beneficial for you.
Yeah. You know, it's hard to be something without seeing yourself in that position, and so in medicine in general, African American men and women, underrepresented minorities represent just a small percentage of the workforce, and they're not always in these subspecialties that are really specialized and have a lot of notoriety, so to speak. So, yeah, I mean, I think I was very fortunate to be at an institution that had promoted someone who was excellent. Um, and it's also given me the inspiration, hopefully, to serve that role for others. So it's been a really fun process joining the faculty here at the University of Washington and continuing to do that kind of mentorship. That's something that's really important to me.
Great, great. Well, you're going to serve as a role model for us tonight. So let's get started. So, the studies are around 18 million men deal with erectile dysfunction, but for the most part, this is something we don't discuss in the African American community. So, why is this something that we just don't discuss?
Yeah. Well, I'll start by saying we don't have a lot of great answers in that domain. I think the future of the type of research we need to do in this space needs to sit black men down in private settings where they feel comfortable and have the discussion as to why, you know, things like sexual health aren't discussed, where the gaps are, where opportunities are to address the needs of the community. Because truthfully, any answer I give you wouldn't be founded in a lot of evidence,
Mm,
unfortunately. I will say that erectile dysfunction is pretty common, right?
mm,
And so somewhere between 10 to 20% of men between the ages of 40 and 70 have some degree of erectile dysfunction. There's literature to suggest that men start to experience it as early as their 30s, maybe even their
mm,
20s. And a lot of it has to do with what's driving the cause for erectile dysfunction in a particular man. So it's a really common problem. I always like to say, medicine and health is not very social. You don't go to the bar or the dinner table, look at your buddy and say, "Hey, let me tell you about this problem I have." Right? That's
Right.
just it's not the way that it works.
Right.
So I think if we want to tease out what the underlying issues are, we have to be really intentional about it.
So, and that's great. And so, what are some of the actual? So, is of the causes individual, or what are some of the causes that you normally see in patients that lead to erectile dysfunction?
So I'm happy to talk about this subject as a urologist, but I do want to give a disclaimer that as a urologic oncologist, there are others in our field who are better suited to have nuanced discussions about
Uh,
sexual health. All right.
Sounds great.
But
Yep.
in general, we divide um, erectile dysfunction as far as causes into a couple of categories. The
Oh,
one is sort of what I would call vasculogenic. These are the causes that are due to impairments or some kind of disruption of blood flow, which is a key tenet of developing an erection. And then the other bucket that I typically tend to put it into is psychogenic. So,
mm,
the mental, emotional components that can affect erectile function. Um, and so those are two different mechanisms. Obviously, you can have a component of both. There's also some neurologic potential causes for erectile dysfunction. Um, I deal with that in prostate cancer surgery, right? So most of the operation that we do for prostate removal impacts erections because it tends to impact the nerves that help supply sort of erectile function. But those are the three general categories that I think are high level ways to think about it.
oh, okay. And so, primarily, psychogenic is definitely meaning that it's somehow in our minds, and our
Yeah,
mind, and it's something that we either can control it or we need to go to some sort of counseling in order to get that looked at or examined in order to, I guess, feel better about
yeah.
our.
Well, when I say psychogenic, you can imagine if you've experienced a trauma, you have a new diagnosis of a serious illness, you've had a death in the
Mm,
family, um, you have a lot of anxiety because you've lost your job. You know, um, these are things that you might not make a straight line connection to the fact that these major life events are impacting your erectile function. But those are the type of emotional and mental events that can impact erections. And so, one of the things that is important to uh, I understand and tease out is that the psychogenic causes oftentimes require some help. They require the discussion about your mental health. Sometimes they just require stability in your life if that's not present at the time. But it's important to differentiate that from sort of I'll call them organic, but sort of the physical ailments that may contribute to erectile dysfunction, such as having heart disease or diabetes. Those are
mm,
very different causes from the former.
okay. And so, with that said, are there, and I don't know if you could expound upon this a little more, but are there any natural things that men can do or changes that men should be making in order to kind of alleviate erectile dysfunction?
Yeah, I mean, everybody is interested in prevention, right? And
Yeah.
prevention can be a really powerful way to stay healthy. And so, you know, I think that when you say natural remedies, that's a different arena. I'm not an expert in that
Right. Right.
at all, and I am very
Eh,
clear with patients about
yeah.
that.
Not
But what,
not necessarily remedies, but just should change. There should be some changes that men
yeah,
should be making in order to.
absolutely.
Yeah.
So eat better, you know, eating well, avoiding fatty foods, high sugar foods, things that would naturally predispose you to high blood pressure or diabetes. Um, or vascular disease in general, avoiding smoking tobacco, um, exercising, right? Things that help you stay healthy. The way I think about it, anything that is good for your heart and your general health is going to be good for your erections.
Okay.
It's all tied together.
Okay.
So when guys ask me that question, I say, yeah, if you can exercise 3 times a week, you can cut out an extra burger, get the smaller fry instead of the extra large. These little things, cut out soda, just being healthier, that will improve your erectile function and certainly can prevent it from getting worse.
And so the main cause why it affects men older, and that's 40, and because of course our we don't get as much exercise as we should as we get older.
Well, as you get older, blood vessels undergo changes that lead them to not be as effective uh, for the vast majority of men, and that's really what is driving it. You know, um, it is the blood flow into the penis that makes it rigid, and so anything that compromises the quality of blood flow to the penis will do that, and that tends to be associated with aging. It's the same reason your risk of having a heart attack goes up as you get older, or having some of the other diseases that are blood related. Kidney disease, for instance,
Hmm.
can be related to blood flow or quality of blood flow. So that's why we tend to see it in older ages. It's just sort of wear and tear, so to speak, over time.
Okay.
That's associated with vascular events for the most part.
Okay. Great. Great. Thank you. So if someone was to, uh, I guess, try to repair their erectile dysfunction from a surgical standpoint, what are some of the things that they can do from the non-invasive to the invasive, and what are some of the risk with
Yeah.
that?
So when I see a brand new patient who says, doc, I've noticed like it gets hard, but not all the way, or like if I start having sex, it gets soft, pretty quickly, or I can't, um, any of the things, right? It's not hard enough for penetration. I mean, there's a list of things. So this is why I think it's a hard area to study, because erectile dysfunction doesn't just mean like, oh, it doesn't get hard at all, right? It's like all the variations in between. The first thing we do is sort of get that history, right? Because I want to be able to tease out if it's a mentally driven thing and process versus a physical. And if we determine it to be a physical, so blood flow kind of issue, then that's when the Viagra type medicines come into play. And that's really the first line of treatment. It's non-invasive, with Viagra. So the common name is sildenafil, and there's a lot of there's at least 3 or 4 different types of those medicines that are available. We tend to prescribe sildenafil and tadalafil the most.
Mm.
The side effects are going to be in some men they can have headache, they can have flushing, they can have runny nose, and then obviously in men who have significant heart problems or are on certain types of heart medicines, it can be it can drop your blood pressure to really low levels. So those are the those are really the side effects, and the way we counsel men, especially those who have heart histories, is to talk to their cardiologist or their heart doctors, make sure they're okay to be on it. But for the most part, pretty well tolerated. Works best on an empty stomach, and
Okay.
definitely avoid drinking alcohol with those medicines.
Oh wow. Okay. That's
Right.
great. Good. That's
So
good to know.
that, yeah. So
Because
that's the
on
first sign.
on a date night, you better make sure you're not drinking any
Yeah,
alcohol.
no alcohol, and take it on an empty stomach. It's much more effective that way.
Okay.
One thing that I think is a big confusing parameter for men is they a lot of guys will when they first try it will say, "Hey doc, I took it, it didn't work," and then I'll say, "Well, did you engage in foreplay? No, like did you what did you do to try and get stimulation going?" So for these medicines to work, you still have to have the normal activities that you would have participated in to achieve an erection. So it's not take the pill and then like wait for it to get hard, so to speak. Okay. And so I think the way you use it also matters.
Uh,
Once,
mm.
go
Go
ahead,
ahead. No,
sorry.
go ahead.
I was going to say, once men have no success with that approach of the pill, then we start stepping up from less invasive strategies to the most invasive, which is a surgical prosthesis that can be implanted
Hmm.
with a pump that you squeeze that gets puts basically saline into some cylinders that get rigid. Men and their partners are really satisfied with the implants, but obviously it's an operation. And so that is the surgical management that is most invasive
Yeah,
along
I
that
did, and I
spectrum.
did read that for those that did get penile implant, that they would be satisfied with it, but I guess it just is a matter of, I guess, changing how you encounter counter sex, because it's kind of okay. I gotta, you know, I mean, can you go into that a little more? I know it.
Yeah.
When do
Well,
you engage into, I guess, pumping, your penis so it gets erect prior
yeah.
to your sexual
So
intercourse?
let's walk through the other couple of agents, and then we'll sort of spend a second on surgical
Okay, sounds, yeah.
implant.
Okay.
So the next thing that I usually recommend for men is a vacuum device. It's one of the tubes you put around the penis. It sucks blood into the penis, and you put a ring at the base of the penis. So that is obviously less invasive than having a surgical procedure. Um, and the vacuum device doesn't involve any sort of medicine being put into the penis. So for some men, it works really well, and they're very satisfied with it. After that, you've got an injection, and there's different formulas that you can mix up to inject into the penis that will make it hard. And then there's a suppository you can put into the tip of the penis that can also help with erectile function. So those are that's the in between phase.
Okay.
Injection to the penis is not benign. That's definitely not like taking a pill, but again, they can work really well. So then that takes us to the prosthesis surgical procedure. So outdone usually with either as an outpatient or a one night stay in the hospital. You got to heal from surgery before you can use it, usually about 4 to 6 weeks. And then the way that the device works is it's called an inflatable penile prosthesis. Okay. So it has a reservoir that holds fluid in it. It's got two chambers that go into each corpora of the penis, which is the erectile body of the penis. And then it has a pump that sits usually in the scrotum. Okay. And when you pump it up, it brings fluid from the reservoir into the cylinders, and that's what makes the penis erect.
Okay.
And so it's whenever a man and his partner want to engage in sexual activity, he just has to pump it to the level of firmness that he deems satisfactory for an intercourse or any activity, and it's ready to go. When we do the surgery, sensation is intact. And so
Oh, okay.
in theory, and this is borne out by the data that you and I talked about as far as satisfaction goes. It should feel the same, but the cylinders um, cause rigidity in the main body of the penis, but the head of the penis is not firm. That's just an anatomy thing that is really hard to overcome. But it works. It works really well. I worked with someone at the Cleveland Clinic that always joked, who's had the prosthesis place in the waiting room because they're usually there. Their wife is smiling. They're smiling. Everybody's happy. So as invasive as it is, I think it can be a really good procedure to consider for the right men if they're having a lot of difficulty with erections.
And how much time does it take to, get rigid? I mean, how much
Not very
time?
long.
Oh,
Yeah,
really?
I mean,
Okay.
you're just pumping it up. So, I mean, we're certainly somewhere in depending on how comfortable you are pumping it up, and I'd say under a minute.
Oh, wow. Okay.
Yeah, quickly. You know,
Okay. Nice. Okay. I
yeah.
guess I was gonna say a joke, but I'll leave that. I'll leave that alone. So, okay. But that's good. I mean, that's good to know, because I mean, of course, there's always not story, but I'm sure there was a movie about it, and I can't remember the movie. And it's almost we tend to joke about these things and not take it
Hmm.
seriously, and that's why I'm glad you're on tonight, because it's like a minute is really not a long time, and you can still kind of at least maintain a sense of, I guess, intimacy with your partner,
Oh,
prior to having to do, what you have to do in order to have intercourse. So
yeah.
that's good to know. So thank you about that. But one of the things is that I also wanted to ask you is that when, and not in general, but when you kind of explain the procedures to black men, what is their sense when they come in, to talk about these things, and then what is their feelings or sense once you kind of explain, how it can help them?
It's a great question. I mean, I think men in general, people in general, I mean, we spend a lot of time training to learn the human body and anatomy. I think there is a lot of apprehension and fear about surgery because there's a lot of unknown, right? And for procedures like this, I think, as you alluded to, men come in and um, they may already at baseline have some feelings about the healthcare system, right? Because there is generational history there that has not always been positive. In fact, I shouldn't sugarcoat it. For the most part, it hasn't been positive,
Right.
especially with surgical subspecialties. And so I think there's naturally a lot of apprehension. I I've been fortunate, right? I'm a black man practicing, urology, and I think um, naturally there is some comfort that other black men get when we meet, and sometimes they're very upfront about that. And it, I take a lot of pride in taking good care of everybody that comes through the door. Obviously, that's just that's what I signed up for. But there is something pretty unique about being able to build the bonds of trust with another man that I know has some apprehensions and fears about what they may be up against. Um, and so for a procedure like this that is, um, you know, can be an outpatient procedure. For me, it's a lot of time spent sort of reassuring that yes, you should wake up from anesthesia. We wouldn't let you have surgery if you're a high risk. Like we expect things to work the way that they're supposed to. That kind of
I mean, and yeah, and it's interesting. You would think, in the drug makers, that we don't even have these issues. When you see the commercials, they primarily feature white men as having these problems, and that we don't. But clearly, with 18 million men being affected, it affects all people of color across the board. And so why does the industry not do more to for it to be more inclusive?
thing. Yeah, I I don't know if I have an answer to that.
Mm.
I do think that in general, um, minority populations, when it comes to marketing, um, and when it comes to sort of the image of things, haven't always been included, and I think that's changing. It's good, I think, because a lot of people have shed light on that. But
Mm.
um, it's really hard to understand the motivations behind that, other than the people who are creating the content, implicitly or explicitly are looking at people who look like themselves and might be framing, the work they do around that. I don't think it's always in the light of wanting to do something negative. I think the impact, um, unfortunately, is that it ends up being negative, right? So um, I'm as an editor for a special issue on disparities in urology, and um, one of the things that recently came across my desk was this question about, is it important if some kind of pathology that's presented in a textbook uh, uses different people's color, different skin colors, right? Because if you don't know what a particular skin thing looks like in a black man because you've never seen it in a textbook, maybe when you see them in real life, it doesn't jump out to you in the same way it does on a lighter, shade of skin. So,
Mm,
I mean, it's got me thinking about the importance of representation in all the domains beyond sort of the things that I think about as far as workforce or, patients participating in, high quality care or clinical trials, that kind of thing. I mean, I think it matters across the board, like you said.
right, 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 great. And so yeah, so let's shift gears a little bit and talk about prostate cancer.
Sure.
My dad, he had prostate cancer, and he survived, and I think because of, and to his credit, has always been one that has always gone to the doctor. Is
Hmm.
very, takes very good care of his health, and made sure that he caught it early enough to get a surgery, and he has recovered. But
Hmm.
for when you hear this word, but really, if you could break down kind of in layman's term, what is prostate cancer?
Sure.
Yeah, I'd love to hear that.
Yeah, so now we're entering an area where I feel like I have a lot more
Yeah.
expertise. So the prostate is the first part of the male urethra. Okay, it's attached to the bottom of the bladder, and this is why when men get older and their prostates enlarge, you might hear about urinary issues that are associated with the prostate. Its
Yeah, like
function.
going to the bathroom a lot.
Yeah, going to
Okay.
the bathroom a lot or having difficulty emptying your bladder. It's because it's that first part of your bladder's trail of emptying urine. Okay, it functions sexually as a producer of semen, so it produces the vast majority of what we call seminal fluid, which is the fluid that comes out when you ejaculate,
Hmm.
and is what your sperm swim in. So this little organ, which sits below the bladder, above your rectum, which is why the finger exam matters, is because that's where we can feel it, is how urine and semen sort of leave the body. Uh, it can be a site where tissue can overgrow. And really, when we talk about cancer, cancer in general uh, reflect the abnormal growth of cells or tissue. And so, in the case of the prostate, you can have one abnormal or two abnormal cells start to divide very quickly, and over time they'll organize themselves into either a tumor or a series of tumors that can be detected. And that's really what prostate cancer is. It's that abnormal growth. The risk of this abnormal growth is that it starts out in the prostate, but the prostate's it's in continuity, it's in flow with all your blood vessels, and so little cells, little prostate, abnormal prostate cells can leave the prostate and implant themselves somewhere else in the body.
Mm.
And that is really when we talk about metastasizing, that's what we're talking about. It's that those cells traveling to lymph nodes in the pelvis or the bone or the lung or the liver. Um, that's a different type of disease that's harder to treat. But when it's located only in the prostate, then we have all these great tools that are really effective in combating prostate cancer.
Wow. Okay. Great. And and I know you start to at what age do you kind of start to really, for men's health, do you start to want to start to look into that to make sure your prostate is in good health?
Yeah, great question. The recommendation currently for screening for prostate cancer, and maybe we should talk about prostate cancer screening
Hmm.
just for a second. So
Yes.
how do
Yes.
you, what activities can you participate in to catch prostate cancer early? Because, in the last answer, I basically said, hey, if we catch it early enough, you got a lot of good options that can give you a cure, cure you of your prostate cancer, like radiation or surgery. Well, the way to detect prostate cancer early, which is unique compared to other cancers, is the PSA blood test. And we usually do that in conjunction with a finger test. But really, the blood test is the key in detecting prostate cancer early. So go get your blood checked. And the test is called a PSA. which stands for prostate specific antigen. And PSA 10 is elevated for a whole host of reasons, but one of the reasons it's elevated can be prostate cancer. And so if your number is high when it gets checked, usually you'll get referred to someone like me, a urologist, and we'll have a discussion about whether or not you need to undergo a biopsy, which would be the only way to really tell whether you have cancer or not.
And I know it's technical, but what would be considered a high PSA?
Again, I wish I could just give you a number. And
Oh,
this is
okay.
where it gets
Wow.
really confusing, right?
Interesting.
Because we
Okay.
know that for younger men, if you're in your 40s, the PSA threshold that we should use is different than if you're in your 70s. So historically in the US, we've always said PSA of 4 uh, or higher is abnormal. But, you know, in a clinical trial done in Europe, they actually use a number of 2.5. And I think if you're looking at screening younger men, so men in their 50s or 40s, then it's you need to be a little bit nuanced in how you think about the PSA number. And that's hard, right? Because I think that adds a lot of complexity. Someone like me who does prostate cancer work all the time, you know, I feel like I've been trained to navigate that nuance a little bit better. But if you're a family doctor seeing a lot of patients a week and you just want a single digit that says, okay, if he is above this number, I should refer him, and it's not always that simple.
Okay. Great. And so I know there was a study. I was doing a little research a little bit prior to the call, and it was stated that even though African American men are you know diagnosed with higher, but it doesn't necessarily mean we are dying any greater than other men. So is that true? And if that is the case, why does it seem like we are diagnosed more with more prostate cancer than other races?
Yeah. So the truth of the matter is that statement um, has a major qualifier. So black men in the United States are twice as likely to die from prostate cancer. That is a fact. Okay. Black men in the United States are 60 to 70% more likely to be diagnosed with prostate cancer every year. That is a fact. I think what the literature has shown recently, and some studies that have been done by my colleagues across the country, and even myself with some folks, have shown that if Black men were to have access to treatment and use the same types of high quality treatment that are available to other men, that the rate of dying might not be any different. And so that is a different qualifier. That is
Mm,
somewhat a reflection of either subsections of Black men who have insurance and access to good care, and sometimes it's just, you know, analysis that's adjusting for certain things. So not somewhat theoretical, I should say. But that's an
mhm.
important thing to really dissociate.
And so is there, and so also with and I just don't know if this is the case, but with being so few black men or even doctors of color in the field, are is there any studies or anything where they're not being diagnosed or I guess checked to see if this might be an issue? Or
Yeah.
is it the fact that we're as black men or just are not going to the doctor, or is it a combination of both?
So I'm going to take a sort of long way to get to answer your question,
Okay.
but I want to make sure I address something you asked earlier, which was at what age should you start getting screened? What age should you get checked for PSA? And so the recommendation is for 55 to 74 years of age is where you should get PSA screening. But we just went through the numbers that say, black men are more likely to get diagnosed and more likely to die. And so there's a group of researchers, myself included, who have really been asking the question, well, should we be screening earlier? And we've had some really exciting data that shows that by lowering the screening age from 55 to 45, even 40 for black men, that you can have a big impact on men dying from cancer. Because one of the things that definitely happens for black men is if they're not getting screened, they're more likely to show up to the doctor with that cancer not being inside the prostate alone. So it's in other parts of the body
Mm,
that
hmm.
no longer have the option for cure. Okay. So
Yeah,
young,
and that's good to know, especially because not to want to cut you off, but not
no,
because
no,
we think that when you hear about prostate cancer, you just think about that. You don't think about, well, the actual cancer is, because it's there, it's spreading to other parts of the body.
yeah. So actually, prostate cancers typically are pretty slow progressing, meaning unlike other cancers that might move more quickly from the first site, which are the primary site as we call it, to other places, prostate cancer are usually on the order of, half decade to decade before it's going to spread to other sites, and maybe even longer, and this is
Mm.
just sort of our estimate. Um, and so there's this tremendous opportunity with screening to catch things early. So you were asking me, why does this happen to black men? Why are we seeing the numbers play out the way that they do? And is it just one thing? Are black men just disinterested in screening, or do they not have access to screening? Or, the list sort of goes on and on and on. And I think I've heard it painted both um, in sort of negative behavioral lights, like, just like black men are afraid of the doctor and they just aren't taking good care of themselves, or lights of, a frame of reference that might say, well, just black men just don't have insurance. But the truth of the matter is, it's a combination of things. And so we talk about the social determinants of health, and we talk about the social determinants of equity in healthcare. And, you know, the way that we utilize healthcare, the way that we interact with the healthcare system is a function of our physical environment. It's a it's a function of our education level. It's a function of our community. It's a function of what food sources we have, our job stability. What physical healthcare facilities are near us. And then overlaying all of that is societal structures and mandates, whether you have housing, whether you have, a world-class doctor at your doorstep that can take good care of you and is
Hmm.
invested, that you have a job that gives you insurance, that you can prioritize your health rather than working three jobs and just trying to keep food on the table. And so
Mm.
it is not a very simple answer to just say, okay, black men just don't like the doctor. I think they're black men, like all men, want to have good health, right? But I
Right.
think the
Absolutely.
system doesn't always allow them to achieve that.
Yeah, and I know, and I'm not sure if you'd heard about, I guess, Respond. I guess it's a
Hmm.
study that are trying to get more black men, I guess, to be tested for, to research. Could you, and you've heard about it, could you kind of expand on that a little bit, and what's the purpose of the study and why is that important? Uh,
Well, I think if you look at prostate cancer in general, it's a disease that has sort of this disparity that's been pretty well described. But the majority of clinical studies that have been done, whether they are traditional clinical trials comparing drug A to sugar pill, or this surgery to nothing, or you know PSA blood tests and not doing anything, those studies have on average had 3% black men participating. And some of those studies have 0% black
mm,
men.
wow.
And so we have a lot of work to do to make sure that we are studying black men to understand what the drivers and opportunities for reducing this disparity is. The problem is that black men not participating in clinical trials and studies in general is a reflection of a lot of things which we've sort of hinted on. I last night was reading Harriet Washington's book. It's so heavy I can only read about 10, 15 pages at a time. But the book's called Medical Apartheid, and she was really in this particular chapter I was reading. She was honing in on, you know, black slaves and poor black, free black persons in the United States being considered medical material, and I use that in quotes, medical material,
Mm,
for teaching hospitals. And this was common practice in the 19th century. Um, you can't tell me that somebody who has that as part of their family history is excited to come enroll in that same academic center's big clinical trial for prostate cancer. I
right,
think
right,
oftentimes we talk about Tuskegee, but there's a timeline. It's not a single event that has created this mistrust. You asked about Respond. It's a great initiative. It's a cancer moonshot uh, clinical trial that's being sponsored by the National Cancer Institute. The goal is to get Black men that have had prostate cancer treatment to engage in a variety of um, questionnaires to get some of this baseline information about who they are, what their motivations were, their experience with treatment, but also to get tissue and blood to see if there aren't any biologic markers that could help treat Black men better.
mm,
Um, it's in its early phases. I'm not one of the investigators of the trial. I do know a couple of them and have had an opportunity to interact. It's an important effort, but I also honestly don't know where they are in the process of getting men enrolled, and ultimately providing some data that will hopefully help us take better care of Black men.
great, great. And so also one of the things you hear commercials about beta prostate, and I guess pills that help keep the prostate healthy. Do are those? I guess in their I don't know if they're called if they're vitamins or what are natural, but do those things help keep the prostate healthy?
Yeah, good question. I To date, I don't know of any literature that supports that those things improve any particular outcome. Those naturopathic remedies aren't always required to be scrutinized in the same way that a drug that goes through FDA approval does. For me, what I tell my patients and the men I take care of is, if it's not causing harm, you know, so if it doesn't have some agent that I know for a fact is not good for you, I don't have a problem with it. I think, yeah, healing and being well is a holistic process, and so if taking something like a prostate vitamin is gonna help you feel better, then I support it. But I can't say it's gonna reduce your risk of having some kind of urinary event or prostate cancer. I mean,
Gotcha.
that's just not
Good
there's
to
nothing
know.
to
Good to
support that.
know. Good
All
to
right.
know. Because you hear the commercials all the time, and of course especially on the sports talk show. So
Yeah.
it's always quite
Well, there are
interesting.
supplements, right? So supplements have a different criteria for making their way onto the shelf than drugs do. So
Okay.
just I think I do caution men, don't do your research, stay safe, but if it's not harming you, then I don't have a problem.
Great. This has been very helpful. I think any education or knowledge that we can gain as Black men, and in an open forum like this, just get people to talk or even at least think about our health, because
Mm.
to try to just think that it's going to go away, or it's some or it's uncomfortable to talk about, is we're doing ourselves a disservice. So the fact that we had an opportunity to talk about it has been great. So I thank you.
Yeah.
Um, but
I will say you said something that really strikes a chord in me. We've been collecting cancer data in the United States since the 1970s. Okay, so since 1970, National Cancer Institute at a variety of sites across the country has been tracking all the cancers in the U.S. And for prostate cancer, since the 70s, Black men have been 60 to 70% more likely to be diagnosed, twice as likely to die. And it hasn't changed, despite all the intervention and the new drugs and the technology. Um, we're at a nexus right now. I mean, this has to change. You know, as providers, I know many of my colleagues across the country of all races, creeds, et cetera, are really passionate about trying to solve this issue and understand it better. You know, right here in the University of Washington, we're engaging a series of studies um, that are what we call qualitative research. So,
Mm.
quite literally, just sitting down with men and talking. And I think until we go to that base level of, I almost call it like market research. That might be the MBA in me, but we got to understand what the problem really is, and we need to understand it from the patients. And then beyond that, I think we really need to invest in making the patients key stakeholders in the studies that we design and complete. So I'm hoping that the focus and energy in this space that exists currently can be harnessed to empower Black men to take control of prostate cancer as a disease process and to help us get parity, equity. It's what we need.
Yeah, and I'm glad you mentioned that because I'm sure most of us lay people don't know that. So since it hasn't really been any, I guess, changes or haven't been able to figure out why it impacts African American men more, is that kind of puzzling, or does it make your job or going to work every day that more challenging because it is a little bit more difficult being also an African American man?
Yeah, I mean, that's an interesting question. We know what some of the big drivers are. I mean, like I said earlier, we know that if we get people the same treatment, the outcomes seem to be about the same. Um, but there's also some data to suggest that, the disease might be more aggressive in Black men. We don't understand anything about that. I think historically we've looked at that and said, okay, Black men must have a different biology that creates more aggressive tumors. That there's a history of using race and biology in that manner that's not productive. And I think that oftentimes points the finger at a community and says, well, the bad outcomes you have is just because you're made up of bad stuff, so to speak. The truth of the matter is the places we live. Are we in a city that has polluted water? Is our community forced to be by the highway or the power plant in town?
Mm-hmm.
These are things that are unmeasured that might be driving our cancer, our cancer risk among Black men, I should say. For me, it's personal because these statistics might reflect my risk someday. They certainly reflect the risk of my cousins, my uncles, my dad. You know, uh, it's the people that are closest to me that bear out these numbers. Um, so if anything, I go to work excited because I know that for me, especially now at this point in my career, I'm at a really great institution with great people. They believe in what I want to do. I'm starting to build a really great team of people that are interested in doing this work. Um, and it might take my entire career. I might be hanging it up in 3 or 4 decades before I can say, hey, we did make a difference. But
Right.
I would be proud of that, and that's sort of where I'm at.
And so I wanted to ask you, just because, which I never even thought about, but internationally, or let's take Africa,
Hmm.
um, are we seeing those same issues? Because I mean, Africa would be predominantly African American or
Yeah.
African, but do we see those same issues in their country as well?
Yeah, so my parents are from Ghana, West Africa,
Okay.
and so I've thought about this a lot. The truth of the matter is, prostate cancer is a really common disease worldwide. In the U.S., 1 in 9 men will be diagnosed with prostate cancer. We say the rate for Black men is about 1 in 6 or 1 in 7. So 1 in 9 here, you go across the pond, so to speak, the risk of prostate cancer, we estimate to be about the same, so probably similar rates. What's hard about studying prostate cancer in the developing world, like in Ghana, which actually has a lot of resources, is the lack of these registries. So I told you in the United States, federal government put a lot of money into being able to track cancer statistics. That is the sign of an affluent country being able to
Mm,
do surveillance in that way. We don't have
okay.
that kind of data. in places like Ghana, at least not to that scale. And so it's hard to do an apples to apples comparison
Oh, I
of
see.
prostate cancer in that way. What I will tell you is that when you look at prostate cancer death, so dying from prostate cancer, where that seems there was data collected by the World Health Organization, places that have large black populations or men of African ancestry populations, so like the Caribbean, portions of West Africa, do seem to have higher rates of prostate cancer death. And so um, compared to other places in the world. So again, is that a reflection of biology? I don't know, but it might just reflect the fact that if you get prostate cancer in Ghana, there is no robotic surgeon that's going to take out your prostate early. Um, there may not be access to drugs that we use commonly to treat advanced prostate cancer, so you're more likely to die. It might be a resource issue. But I think it's an area to study, and some really talented scientists here in the U.S. I can think of a couple that are up in Boston have decided to go straight to Africa, collect um, data to try and answer this question. Is there a connection between some of the statistics we see here in the U.S. and what's going on abroad?
Wow. Okay, great. That's good to know. And it's, I mean, I know we focus on, on America, but maybe, that may be a great place, especially when we look back at our ancestors and, and if we see markers and it may be helpful, down the line, and hopefully you'll be able to be a part of discovering something. So, I'd love to hear about that. And I thank you. So, but we, always want to end the show because, even though the Black Men Speak podcast we want to really hear what people are doing in the communities. We always want to know how you're doing. And so as a Black man, what's on your mind right now?
Man, that's heavy. That's heavy. A lot, a lot. I think we started the show with why did I decide to do urology? And I told you it's just role model. And so there is a tremendous amount of pressure that I put on myself, not only to take care of my family, but to be a shining example that someone that can look like me, um, can truly be excellent as a clinician, as a researcher. And I don't know if that burden is any different from anyone else who's motivated and hungry, but I do see that lens. I do see things through that lens that, maybe if I don't do my job well, others behind me don't get the same opportunity. Um, and then just, and that's somewhat maybe a little bit selfish way of viewing it, or a little egotistical. I don't know, but it is a burden that I carry, and that's something I think about for other Black men who are trying to be a shining example in their communities. It can sometimes come with a lot of pressure to not fail. And ironically, failure is a part of life. The failures are sometimes how we get better. Um, but doesn't seem to sometimes be a lot of room for that. Um, Second thing for me is we were talking about family at the beginning of the podcast, and um, I have a 20-month-old son. I have a 4-year-old daughter, and I'm always thinking about what this world I'm leaving behind for them is going to look like. Now, are they going to face the same struggles and challenges that I faced, right? It's it's interesting to me when I talk to friends sometimes, because of what I've accomplished, right? Being a physician, sometimes folks think um, some of the tough things that can happen for a Black man in the United States that we're not privy to, right? Um, and so I think that weighs heavily on me. Will my son feel safe in his own community uh,
Mm, yeah.
in a couple of decades?
Yeah. And I've heard that from several of the brothers who've been on before. What are we going to leave behind, or for our kids. And I think by the mere fact that you're the research that you're doing on a day-to-day basis, trying to not only find a cure, but you're trying to find what are the causes that are affecting men with, especially with prostate cancer and the like, and showing up every day to do your best, I think is a testament that is a pretty good legacy that I think your kids will be proud of. So just wanted
thank you
to
so
say
much.
that, and but I thank you tonight for being on. I know it's about 4:00 there, so thank
Yeah.
you for being on this afternoon, and hopefully you can enjoy the rest of your Sunday.
Thank you. Again, this has been such a wonderful conversation, an important one, and who knows, maybe there'll be an opportunity for us to circle back in the future.
Yeah, and so as we close, kind of the last thing, if someone is, because I don't even know if there would be any symptoms, or what would be any symptoms of prostate cancer, and what should be kind of the first 2 or 3 things that someone should, if they feel not feeling well, what would be some of the signs they need to get checked out?
Yeah. Well, early prostate cancer usually doesn't have any symptoms, and so this is why the blood test is so valuable and the PSA test. Most of the time when you're showing signs, symptoms of prostate cancer, quote unquote, it means it's really advanced. It's likely spread to other places. Some common signs maybe of local things would be difficulty urinating, blood in the urine. These are things that, in addition to other potential malignancies like a bladder cancer, prostate cancer would be on the list of things to think about. We talk about bone pain, unintentional weight loss. Again, things that are signs of pretty advanced cancer, as being other signs or symptoms. But truthfully, this is one of the unique things about prostate cancer, especially in the early phases, is you may not have any symptoms at all.
So basically, around 45, and definitely by age 50, black men should demand they have a PSA blood test.
I say if you're healthy, and even if you're not healthy, but especially if you're healthy, between the ages of 40 and 45, I think it's very reasonable for a black man to advocate to have that blood test done. And there's actually some interesting data that, depending on what that number is at age 40 or 45, it probably predicts your risk over your lifetime. And you might have a low enough number that a clinician could scale back and not check you every year, or your number might be such that, you can start to put yourself in a category of annual testing. But I strongly, strongly, strongly push for black men to consider it earlier testing. And I think we're going to have some good data to support that soon.
Great. Well, you heard it here first. Brothers, go get that done. You're 40 or 45, and mark it on your calendars. Let that be your birthday present at age 40. So, Dr. Nyame, thank you. Nyame, is that right?
It's funny. It's actually Nyame. Like if
Nyame.
you went
Okay.
if you went to Ghana, you'd say Yaw Nyame. But I've been in the U.S. so long that I say Nyame, and I've accepted it. So,
Well, Nyame, I want to get it right. Well, thank
yeah,
you,
yeah.
and you have a good night. Thank you.
All right. Take care, Keith.
Okay, now.
Bye.
Bye-bye. So yes, this is the Black Men Speak podcast, and I just thank you guys for being on tonight. And if you didn't listen, or if you are a spouse of a husband, or boyfriend at age 40 and up, make sure they get their PSA blood test and start to check on these things, prostate cancer, because we already have enough issues and brothers are dying, and we don't need to do that. So if we can prevent it as much as possible, really appreciate it. So if you didn't hear tonight, you can always catch us on our podcast on wherever you get your favorite podcasts. It'll be up next Monday, So I thank you for being on, and make sure you share. This is very important information that we need to have in order to be well in our communities. So have a good night, and I'll see you guys soon.